Again, welcome everybody. Thanks for joining us for the Robert Wood Johnson Foundation Systems for Action Research Program and our regularly scheduled Research in Progress webinar series. For those of you who might be new to Systems for Action, we are a signature research program funded by the Robert Wood Johnson Foundation, and our mission is to study ways of helping medical, social, and public health systems work better together to tackle health inequities and improve population health. We fund a whole variety of studies around the country, testing different ways of aligning delivery and financing systems across those sectors, medical, social, and public health sectors. And we do this Research in Progress webinar series a couple times a month, featuring every session featuring one of our research teams, a chance for them to catch us up on what they're learning through their research progress. And that's what we'll do again today. I'm Glenn Mays, coming to you from the University of Colorado, where the National Program Office for the S4A program is located. And very excited to introduce a collaborative research team based in Texas and Utah, who will be sharing with us their research in progress to date in studying the effectiveness of homeless service networks and coordinating services during the COVID-19 pandemic. So I believe our presenters today, as I mentioned, like a lot of our S4A studies, these studies are led by collaborative research teams. The research team we're going to be hearing from today includes Dr. Hee-Song Yang, whose bio is showing up on the screen right now. She's a professor at the University of North Texas in the Department of Public Administration, and studies a whole variety of issues relevant to aligning delivery and financing systems, including issues around governance and collaborative partnerships between government and the nonprofit sector. One of her key partners in this research is Dr. Jesus Valero, who is a faculty member in the Department of Political Science based at the University of Utah. And Jesus has a strong record of research in looking at government nonprofit partnerships, studying leadership strategies in nonprofit organizations and collaborations, and the impact of technology in various public sector endeavors. We're also fortunate to have another collaborative member of this team, Michael Nichols, who is president and CEO of the Coalition for the Homeless, lead agency to the Way Home Continuum of Care. And Michael's bio is also on the screen now as well. So we will have a chance to hear from all three members of this research team. And we'll also, as we always do, make sure to have reserve time for questions from all of you who are joining us today in this webinar. I encourage you to ask questions, and to do so, I want to call your attention to the Q&A icon that you should see at the bottom center of your screen. You can click on that Q&A button. You can type in your question at any time during the webinar today, and then when we get to the Q&A portion, we'll get through those questions, and so we'll look forward to that. So with that, I am going to turn it over to Dr. Jang.
Awesome. Thank you. Thank you, Glenn, for the very nice introduction of our research team. We are a team of researchers to study homeless service collaborations in very diverse kind of dimensions. And I believe some of team members are attending this webinar as well. So the presentation today is a mid-report of two-year research project to study how homeless service networks experience COVID-19 pandemic and responded these challenges caused by pandemic in coordination of service community. So I'll read the half of the presentation, and my colleague, Dr. Jesus Valero, will cover the second half of the presentation today. So this is our focus of the presentation. First, we will explore the work of Continuum of Care homeless service networks and discuss the challenges and the disruption they experienced, and report how they responded to the challenges and disruptions by reporting two of research project we have conducted and we are conducting. First one is qualitative research based on interviews with CoC leaders that was conducted in last year, and the quantitative research that was based on the National Survey of Homeless Service Networks. And we hope to engage with the audience today to learn from your knowledge, your experience, and your inspiration that you earned from this very difficult time of the history. So that's today's kind of plan. So before we go about research presentation, I want to share what we have learned from 2021 point in time homeless count. So obviously 2021 homeless count was limited because of very difficult circumstances caused by pandemic, and this HUD gave this option to the CoCs to count only sheltered homelessness of their communities. So we are reporting this sheltered homelessness measured in nationwide. And one of notable change was a steep decrease of sheltered homeless population by 8% between 2020 and 2021. And with this limited view, the notable change of 2021 pit count was steep, the decline was observed in families with children. That was like a kind of 15% decrease, and homeless veterans. In a time with these changes, we are also seeing the increases from chronically homeless, more than 20%, and unaccompanied youth Native American, 21%, and unaccompanied youth who were non-gender conforming. That was very depressing, of like 35%. Among sheltered, we are again observing the population was disproportionately represented by the 40% Black and 22% Hispanic. And this largest number of sheltered homeless populations were observed in major cities. So New York City is one of these kind of, the state and the city is kind of a location that concentrated populations, and the LA Metroplex is the second to the New York. Next slide, please. So historically, the service systems for the homeless been very much fragmented, and this fragmentation has been exacerbated by the silos between public health, medical care, and social service sectors and industries. So in response to the difficulty and challenges caused by this fragmentation, the Continuum of Care homeless service program codified by the federal law, and that is designed to build a community-wide commitment to connect cross-sector industries and build cross-sector collaborations of organizations to address diverse needs and challenges facing those experiencing homelessness. Pandemic challenges demanded CoCs to develop whole community coordinations to continue services to the most vulnerable homeless populations, because individuals experiencing homelessness are more vulnerable in COVID-19. So can you go back to the COVID-19 pandemic? But the problem is they have a less access to the public health systems, and government guidelines require these shelters continue their services, not to exclude those who are confirmed positive. And even with these federal fundings, those fundings were predominantly focused on prevention of homelessness and leaving these major healthcare cost and demand to the local government and the nonprofit organizations. Next slide, please. So the Continuum of Care homeless service networks are developed to be a system alignment that is rooted in theory of collaborative governance. The collaborative governance explains that complex community needs cannot be solved by a single organization or the single sector. With effective system alignment, the probability of addressing these complex social needs will be increased exponentially. So as described in this figure, we hypothesize in our research that COC system alignment will have an impact, positive impact on health and health equity of homeless. And the COVID-19 disruption will also impact the work of COC homeless networks in achieving health and health equity of homeless. Next slide, please. So this is our research questions that is leading our 2-year research project. First one is, what are the COVID-19 challenges and disruptions to the COC homeless services, and how well COC perform in addressing health and human service needs surged during the COVID-19 pandemic? And the last research question was what are these conditions that is affecting success of COC homeless service networks in achieving health and health equity of homeless services? So for this research, we use mixed method approach. Is combining qualitative and quantitative approaches by starting with review of federal programs and laws and state and local policies. And we conducted this interview of COC lead like the networks in year 1 of 2021. And we are conducting national survey of COCs in this year, 2022. So next slide, please. So year 1, we conducted the semi-structured interviews with 26 COC network leaders. And I believe some of the audience were these interviewees. We had the interview for this like a year 1 project to understand these challenges and needs created by a pandemic. For this study, we were very lucky and we are very grateful to have these 10 major city COCs and 11 suburban COCs and even 2 rural COCs. So next slide, please. From our interviews with these 26 COCs, one of the major findings was these COCs had opportunity to develop this interdependency, effective interdependency between government and non-state actors by receiving multiple sources of government fundings. So the COC program grant was kind of highlighted in support of pandemic responses, and CARES Act fund has channeled to the COCs in the form of emergency solutions grant and CDBG grants. And American Rescue Plan also had indication of prevention and support of homelessness. And their plans are more longer term compared to other sources of fundings. And FEMA had their plan of supporting shelter services by creating public assistance programs. And at the same time, some upstate, which has a high number of homelessness, created their state fundings and state programs. So Room Key program by the state of California is one of the notable kind of program, and some of the city like the Austin's, the Texas, and the San Diego and California created their own local funding in support of services for the homeless. And most of CoCs informed us they had opportunity to receive this funding support from the community foundation when they were struggling to wait for the federal funding to come to their account. So that was very important and notable findings from our year one research projects. So the next slide, please. So for understanding of these qualitative data that we that we collected, we used this Lester Salomon's third-party government theory and with understanding with focus of 4 dimensions of volunteer failures. So in a very kind of simple presentation of the key findings, we can say these CoC experienced resource limitations, even with these source quite much of government funding that has been dedicated in support of homeless prevention and services for the homeless, because these services has to be housing based, and this housing has to be individualized housing, and that's very costly, and many of CoCs were not ready to move these services available. And the nature of government funding, the funding flow was very slow and left many of these nonprofit organizations in a very hardships to pay their kind of services in a timely manner. And now they are experiencing that under these amateurism conditions, they experience difficulty because these directions or the informations were contradictory to each other, and they didn't know and these contradictory informations and directions left them confused and directionless, and many of them didn't have the emergency plans to exercise. And particular reason conditions, many of them were focused on more of the homeless services and didn't have much of connections to the public health or medical field yet. So they had to make a special effort to be tightly connected with these service industries to provide timely and effective responses to their homeless population. And so under this paternalism, some of CoC informed us they made a special effort to create the board governance form that is combining these cross-sector stakeholders and cross-service industry to create more comprehensive service plans. So that is my kind of first part of the presentation, and I would like to invite Mr. Mike Nichols, who is the CoC lead agency CEO in Houston in Texas. And he was one of the interviewee for our first year project. Mr. Nichols?
Thank you very much, Dr. Yang, and to this team. The Houston Coalition for the Homeless covers 3 counties. We're the lead agency for the Way Home. Briefly, in 2011, HUD said Houston had one of the worst homelessness problems in the country. They gave us technical assistance. The philanthropic community government led by our mayor, Denise Parker, as well as nonprofits got together and made some major decisions. It was the same time as the Hearth Act, and at that time the CoC was developed, the steering committee, as well as the choice of the coalition's lead agency. I came aboard about 3.5 years ago as the lead agency, but had some financial and organizational issues. We revamped our board. We're a 501c3. I will say that I really like the system we have in Houston. When I saw it, I didn't think it would work. it didn't make sense that government would be the major funder and a nonprofit would try to braid those fundings with private funds. But it's worked amazingly well. And I would say, as I compare ourselves to other cities and counties where the COCs embedded in government, this has actually been much more successful. We're seeing people come from all over the country to see what we do. I do urge you to read the New York Times article by Michael Kimmelman, which describes what Houston has done, along with an op-ed in the LA Times that says what LA could learn from Houston. We in Houston, being the number 4 in everything and sort of the outlier, are very proud of this work. The question is it unique to Houston? Is the unique nature of our philanthropic community, our nonprofits, and our government unique? I'm arguing that it's not. I think it is repeatable in other cities, but it takes a lot of work. It takes government stepping back, and I'm going to go through what happened in COVID to us. On March 13th, 2020, the day my granddaughter was born, I got a call from St. Joseph's Hospital, a private hospital in Houston, saying that a homeless person was leaving who had tested positive with COVID and was sick. What am I going to do about it? And I said, that sounds like a healthcare problem. So I called our public health agency and they said, Mike, we are overwhelmed. We don't know what to do. It's your problem. So for the first time, we got the city and the county together in the same room. That's key to get these government agencies together. They had never been in the same room on anything important. And we told them the problem. We set up a separate, additional emergency shelter. We set up a testing site. We set up a motel for people who are sick. And at the end of the month, I said, this is outrageously expensive. And we're talking millions of dollars. And I said, why can't we just house these people? That's the answer. And of course, housing is always the answer. And that's what the focus of Houston has been, is housing as many people as possible, as quickly as possible. And so the city said, you can figure out the federal funding. It's all complex. Tell us what to do. And the brilliant women on my staff put together a $65 million program using only federal money, because we don't have access to local money because of our terrible state government. And they did a great job. The city and county put together $59 million in federal funds. We raised $7 million. And with that, over the next year, we housed 7,000 formerly homeless people. It was an amazing product, and the results have been outstanding, but it took 3 things. And this is the key. When we say housing, what we mean is it's a tripod of actual units, apartments, keys, locks, doors, the roof, air conditioning, heating. It's a real place to live that people can live for a long time. It's not an emergency shelter. It is not a motel room. It is the real place that they can live forever. And that's one. The second is funding for these subsidies for the rent. And that came through the federal government's emergency housing vouchers. There were plenty of them. That was unique. The third leg is nonprofits who do this work, but are paid to do it, not volunteers, are paid to do this with a standard of practice and using funds to do that. And we had the money to do it. And then we had the extra philanthropic money to add the things we couldn't do with government money because it is so rigid. And I will make the argument that anti-poverty funds are highly policed, much more than business funds. And you can compare the PPP or other items to this. I mean, we have auditors all over us all the time. That didn't happen to businesses. And I was in business for 35 years before I got in the nonprofit world. And that's a real issue, but something we deal with. But the success of putting governments together, a variety of governments, and do this. So the main thing I want to say is that the unique part of our work is that we are a force multiplier, which means that we bring in 100 different nonprofits and government entities into our work and try to figure out how they can work to house people. And the second thing is we believe in collaborative effort. I am a believer in good government. I really am. And you say, well, why can't government do it by itself? I don't know that answer, because normally you need somebody else to make that collaborative effort between government and other governmental entities and nonprofits and philanthropy. And we were lucky enough to be able to do that. Houston, because we're a city that government and philanthropy and nonprofits and corporations work together, maybe, but I don't see why other cities can't do it. But government has to give some way. Nonprofits have to give some way. They can't do their own thing. They have to give some way, and everybody has to be focused on housing as the answer, housing with support services. Last, we are going to talk about healthcare. I've got a problem. Houston has more dollars in healthcare than maybe any city in the country. We have tens of thousands of hospital rooms, best hospitals in the country, rich philanthropy in the hospitals, and not $1 goes to homelessness. They do $500,000 services on a homeless person, then leave them out on the street. They try to have some social workers, but until there's housing, that's impossible. And one of the things I'd like to see entities like the universities and Robert Wood Johnson and other philanthropic entities do, is force these hospitals to work with our system. Talk to them about they can't spend all their money competing. They have to spend money figuring out how they do it. So the last is, this is fiscally and morally responsible. Here's what we know in Houston. It costs us about $17,000 to house somebody with supportive housing, $17,000 a year. What's it cost to keep them living on the street? Harris County costed it out at $98,000. I think that's too high. I think a number closer is $50,000, but we can't get the numbers because we can't find out what private hospitals are spending on indigent care because they don't care. We have to get those numbers. And if we did, people would say, let's house people. We know it costs $35,000 to $40,000 a year to put somebody in jail. And we know that of the 10,000 people in Harris County today who are sitting in Harris County jails, 5,000 say they have substance or mental health problems, 3,000 say they're homeless. And that's ridiculous when we could house people for much less. What are the results? Spectacular. Even housing people who are the most vulnerable, those who are the most least likely to succeed, has come out with an 85% success rate, meaning that they stay there for 2 years and more and begin to solve their problems. To try to help somebody with their sobriety or their drug abuse or their mental health and having them live on the street is zero. Doesn't work. So house people first, force this collaboration, talk to the hospitals, don't give them a dime without forcing them to work within the system. I think the study is great. What we learn, yes, we need stronger connections with medical services community that don't serve directly the homeless, but do any kind of work that they're not paid for. It requires greater active community collaboration. Our rural areas and the suburban areas around Houston don't want to help. They should be forced to help. Equity and diversity, it is an issue. 80% of our homeless population in Houston is African American, while they make up only 19% of the population. Big issues. We have a systemic racism within our criminal justice system. They get out of the criminal justice system and they cannot be housed. The state government doesn't even allow them to be housed in the units that they build with their own tax dollars. That's ridiculous. Again, it's a real problem. Income's an issue. So we have to keep working on diversity and we have to build this equity issue. Housing is a big problem in this country. It is a big issue. It should be one of the biggest issues for our politicians. They don't see it. They don't see it. And we need housing of all sorts. And just on a little off-site, in Houston, which has always had affordable housing for the richest to the poorest, is losing that at a tremendous rate because we're not building. Why? because we stopped allowing immigrants into this country who have built this housing in Houston, at least. So again, lots of interconnected issues, but housing is the key. And I don't know any other way to say it. We spend so much money on healthcare and we forget the social determinants of what housing, in my opinion, is the greatest issue. So I like your study. I think it's going to be great. I love the issues around healthcare. I like the issues around continuum of care, building advocacy for homeless programs, something we need to do. We don't have it at this time.
Thank you so much, Mike, for joining us and for allowing us this incredible opportunity to learn from the case of Houston. I know you got to jump off, so we appreciate you being here today and look forward to connecting with you very soon.
Thanks so much.
So I'd love to continue this conversation and share additional findings out of our work. And so as my colleague shared, we are in the middle of data collection. We've completed year one where we engaged with communities across the US to conduct case studies of those select communities, particularly those with high incidences of homelessness, as well as functioning within high sort of rates of COVID-19 transmission. And so in our current sort of year of research, we're in the process of conducting a national survey of CoCs to understand the pandemic challenges more systematically, as well as performance with the focus on adopting a model that my colleague and some of her colleagues have been sort of developing over the past couple of years, a model that they're calling disruption, ambiguity, innovations, and challenges. And so applying this model to our work, we're wanting to understand the effects of the disruption being COVID-19 pandemic on homeless services and the degree to which that's sort of creating ambiguity, maybe leading to some innovations and also into some challenges in how that's sort of shaping the service continuity and response efforts to the realities facing communities in terms of challenges generated by the COVID-19 pandemic. And so CoC participation in our survey thus far has been about 80 CoCs or so that have completed the survey. And so we started off by wanting to learn about their choice of network governance. And so we want to understand the degree to which they're engaging the variety of different sort of sectoral organizations from, public health, the medical sector, as well as the social service sector and beyond. And so the majority of these sort of networks are responding and sharing with us that they have a community-based sort of shared governance model, 34% of them. Which this means is that they're working closely with other community partners and sharing responsibility of how they're sort of responding to the pandemic, responding to local needs. And the decision-making process is not one where a single entity is sort of leading the charge, and instead there's a group of them who are working together collaboratively to respond to local needs and developing those decisions together. The lead agency model, which is also a very common sort of structure of governance, about 25% of them, or 20 agencies, or 20 CoCs, I'm sorry, total responded, sharing that they have a lead agency model where a single entity, usually a county government or city government or a nonprofit in the community, is taking the charge, leading the collaborative effort, and supporting the work of the community. The network administrative organization model is the next sort of common model at 21%. An NAO refers to an organization within the community that's completely sort of developed for the purpose of managing the affairs of the network. And so this organization is basically providing the backbone support to the collaboration process, staffing sort of the collaboration process, often also managing the budget and resources that are flowing into the community and providing that sort of support to the CoC. About 2.5%, so basically about 2 are governed by consulting groups, These are, private sector entities that have developed expertise in managing, leading, supporting, staffing, providing administrative support to CoCs that are much smaller, that don't have the resources, supports to be able to manage their work efforts on their own. And then we had about 17 or 18% of CoCs reporting some other sort of structure. And we're in the process of studying those different structures. But what we're learning is that there's no cookie cutter. There's not just one way of arranging yourself as a CoC. Some of them are, network administrative entities that also not just provide administrative support, but provide service provision as well. And so they're a nonprofit created for the purpose of managing the CoC's efforts, but at the same time, not only provide administrative work, but also provide some sort of system alignment effort in the community too. So some very dynamic models that allow for the CoC to engage a variety of stakeholders in the governance process. We asked them about services that they're providing in response to the pandemic. And so this is our effort of answering one of our key questions of, to what degree are they successful, and in what ways are they supporting individuals experiencing homelessness and in achieving health and health equity. And so a majority of CoCs report that they provide individual isolation sites for people who are confirmed to be positive for COVID-19. Many of them are also providing place-based medical services, including access to COVID-19 vaccination, overflow sites in cases where there's a large volume of individuals coming through their shelter system. Many also use strategies developed for previous pandemics, including Ebola and the H1N1 swine flu. So some of these CoCs have developed strategies that were informed by previous pandemics and adopting them as best practices in order to successfully deal with the challenges that were brought upon by the COVID-19 pandemic. Allowing people who are living in encampments to remain where they are. This is a prevailing story in many of these CoCs who shared with us that they were making efforts for allowing people to stay where they were, finding them, getting to them wherever they were, and in providing services there, including vaccination efforts and the like. Protective housing for people who are at increased risk of severe illness from COVID-19, about 56 or 70% of CoCs providing that kind of support. Mobile clinics, street medicine team, nursing beds at shelter, or a variety of other services that some of these CoCs were providing to individuals and families experiencing homelessness, and particularly with the attention to medical care to these needs. Some of the challenges that we're learning in serving homeless population in response to COVID-19. I think many of you in the call will relate with many of these challenges that I think were not always necessarily unique to homeless serving organizations, but to a variety of other sector entities too, working in other spaces. But one of these top challenges facing homeless serving entities was just the turnover of staff working on homeless services. We kept hearing stories of burnout, of individuals just facing mental health challenges, or just being sick themselves with the COVID-19 virus, and so not able to work and having to take time off. 73% of them reported this challenge. And of course, as a result of decreased sort of social interaction, to avoid the spread, a significant decrease of available volunteers, people not willing or able to be on the front lines for a number of reasons. So that's another significant challenge. Housing services, including emergency shelters, reduced significantly, especially in the early phases of the pandemic. Delayed and slow decision-making by government leaders, another major challenge that we learned about from our interviews, and as well as through the survey of just the challenge of not, hearing directly from city, state leaders in terms of, the strategy that the state or the city was adopting in response to the pandemic. The spread of COVID-19 among homeless population was another significant challenge. Lack of capacities in general to not just respond to the pandemic and the challenges, but also in managing resources that were flowing into those communities was another significant challenge. the lack of government attention to the homeless population in the early pandemic, inconsistent government instructions. In some cases, also the COC board was inactive or not fully engaged in the governance during the pandemic. We heard a lot of these stories where, entities that were, previously actively involved with the board and with other governance elements of their COC work completely just sort of went focus on just the work of their individual organization and trying to sort of address needs that were unique to their organization. And so as a result, not able to fully engage with the work of a collaboration. A shortage of financial support, lack of collaboration, and difficulty of developing virtual communication channels were some of the other challenges reported by some of these COCs. Some specific COC efforts to address inequity in homeless services, particularly in the area of healthcare and medical services. One of the top challenges reported by the COCs was the vaccine hesitancy, and addressing that through education, outreach, and other tactics to inform, better educate, and connect individuals facing homelessness with medical teams in order to get this sort of issue addressed and get folks to get vaccinated and a safer sort of condition to being exposed to the pandemic or to the virus. Number two, advocated for vaccine allotment for homeless population. In the early phases of the distribution of the vaccine, there was no sort of special allotment for homeless population. And so many of these COCs were working really hard to advocate for the vaccine to be specifically sort of set apart, or a number of them, particularly for individuals experiencing homelessness. So about 93% of them reported this advocacy effort. Provided homeless population with vaccine brand option, the Johnson & Johnson, the Pfizer and the Moderna vaccines, so 75%. And this is an important equity issue that was brought by the COCs reporting through our survey as well as through our case studies. Of not just giving the single dose because it's easier, particularly the J&J vaccine option, but expanding that so that individuals had, a choice of vaccine, developing culturally relevant materials to educate homeless population, conducting medical street outreach encampments and other unsheltered locations were some of the other strategies, using some of the CARES Act funding to programs that address health inequities of the homeless population. Collecting data was another important piece and strategy of at least half of the COCs that have responded to our survey so far, to better understand the spread of COVID-19, the vaccination rate, mortality rate among homeless population, in order to have a better picture of what's happening within the homeless population themselves. Developing a COC-wide ad hoc committee or establishing a standing committee to focus on the healthcare needs of their homeless population was another important strategy reported by about 27 COCs. So what have COCs learned from the pandemic? Many of them are reporting that they've achieved wider and more active community collaboration from all the sectors. And we learned so many stories where some of these COCs are reporting that the pandemic really brought many of their community stakeholders together in a tighter way, in a more active way, in a more engaged way that allowed them to develop more systematic, more thorough, more deep sort of plans that allowed them to be more responsive and more effective in the degree that they're able to serve the homeless population. A stronger connection with the medical service community that also serves the homeless population. About 73% of those reporting via our survey began actions to address equity, diversity, and belonging in homeless services was another important lesson learned of looking at ways to include the voices of previously homeless or currently homeless individuals in any kind of strategies that they're developing, and engaging them into deeper work of the COC, including engaging them in the COC board. Increased permanent housing capacity for long-term use as a result of the pandemic, and building public policy advocacy for homeless programs was another important lesson learned from the pandemic. So moving forward, in bringing my side of the presentation to a close here, We're looking to produce a comprehensive report and publications based on our case study work. We've got one paper that's going to be submitted for review very soon. And so all of this work we're hoping to make available via the Systems for Action website, and particularly our sort of profile. So if you'd like to learn more, stay plugged in, please, with us via the website, and as well as communicate directly with us. We're looking to also complete our survey data collection efforts. We've got about 80 CoCs responding. If any of you are on the call, we'd love to connect and look for ways of making sure that your community is represented in this national survey of hopefully best practices of how some of these CoCs are responding to the pandemic, as well as strategies that they're adopting, so that we can all learn from these experiences and better develop strategies moving forward. We're also, through our data collection efforts, hoping to, and this is part of our next efforts of assessing the degree to which networks have been successful in achieving results. We gave a little bit of a glimpse today, but we're moving forward into a deeper analysis of the effectiveness of these networks. And so we're also working to identify those key community conditions, capacity sort of conditions, leadership conditions, that affect and are associated with the successful response to the pandemic. And so this will lead hopefully to additional research publications highlighting factors associated with network performance during the COVID-19 pandemic. And we hope to share these findings with all of you and beyond in the next couple of months. So thank you so much for this opportunity to share an update on our continuing work. And so we're just wanting to express our gratitude and thanks to the Robert Wood Johnson Foundation for their incredible support of our work, and for the partnership of the System for Action office team. They've been fantastic in supporting our work. And so thank you so much, and we look forward to engaging in discussion with all of you here today.
Fantastic. Thank you so much, Dr. Valero, and thank you to Dr. Jang, who started us off, and also thanks to Mike Nichols, who we heard from in the middle there from the Houston Coalition for the Homeless. So we are at the Q&A portion of our webinar today. So we would welcome you all to anyone who's with us on the webinar who's got a question, would like to hear a little more about something that has come up today. Please feel free to type your question into the Q&A box, which you should see on the bottom center of your screen. And I'm not seeing any questions at the moment. So Dina, if you can see questions I can't, please let us know. But maybe for starters, I'll take the moderator's privilege and ask a question to see what Dr. Jang and Dr. Valera may have to say. Interested to hear more about issues around getting the healthcare sector more actively involved in these collaborations in the CoC work. We heard from Mike Nichols, who made a passionate observation about that being one big problem that Houston is facing, is getting hospitals, he mentioned in particular, but I'd say that probably generalizes to the broader healthcare sector, getting them involved, financially as well as otherwise, in helping to meet the needs of this population. So, wonder if you could say more about what you're learning about healthcare sector engagement, opportunities and constraints in these kind of collaboratives.
Yeah, that's very, very important kind of topic that we have been studying since the first grant support program, like research from RWJF. And so there are some of best practices that we observed. One of them would be like the Texas Dallas community, where they have public, like a county general hospital, like Parkland. And recently, like in last 10 years, let's say that they created this collaborative coordination body that is engaging these like this county hospital and the shelters and the private hospitals, the ER department, because they understand no action is more expensive than their coordinated responses. So to these, like the hospitals too, because they have to have a emergency discharge plan, that because in a law they cannot really let the person released to the streets after the treatment. So they have their interest to be connected with, so the hospital and the ER had their interest to be connected with homeless service industries. But they, even with these best practices, they are experiencing difficulty of sharing information and data, because it's this shelter industry had their own data system, and when the hospital has their own data system with very steep restrictions of sharing these informations, and the shelter had their own conditions, so they cannot really accept any patient or the person to reside with certain restrictions of the family restriction, gender restrictions, and time restrictions, and health restrictions. And the shelter has limited service capacity to serve these people with oxygen tanks, or they don't have these like respiratory bed. So there are many barriers, but we are seeing this positive side from some of best practices. They created this kind of ongoing coordination efforts. So yeah, that's not easy, but there's some kind of positive side. I don't know whether Jesus have something to add.
No, yeah. The only thing I'll say is that, there's no question that the integration, the engagement of the medical sector is incredibly important. And in all of our interviews, there is an expression of importance of engaging this sector into their work. But one of the prevailing challenges to doing so really boils down to patient information and the willingness of some of these providers connecting in meaningful ways via, sharing information about particular clients, especially those that are, high utilizers of, emergency rooms, or that have significant medical challenges. And this is all then connected back to, the fact that many of these individuals experiencing homelessness, don't have healthcare insurance, don't have, ID cards, don't have sort of records that allow these providers to, one, understand their background and needs in a deeper way, personal way, but then, the inability to share some of this data and information with other providers, really prohibits, the meaningful engagement of some of these sectors into their work with other community organizations. And so this data sharing, the HIPAA compliance, and other sort of factors really do play a role in the ability of some of these providers working more closely with their local CoC.
Fantastic. Thank you both for those responses. Can we invite folks to submit questions that you may have? I want to ask another question that kind of popped into my mind, Dr. Valera, as you were making some comments, and it's thinking about the role of governing structures in helping to facilitate these collaborations, alongside the role of effective leadership within these coalitions. I wonder if you can share more about your learnings about those two aspects of collaboration, governance and leadership here. And we often, in thinking about, back to Michael's comment about replication, can Houston's success be replicated in Los Angeles? It seems to me that governance structures can be more easily replicated than can effective leadership. I mean, not every community has got a Mike Nichols in it, with his background and passion. But governing structures, sometimes can be a little easier to replicate. So I wonder if you could share more insight about just the interplay of those factors in these collaborations.
Yeah, absolutely. I'd be happy to take a stab at that first. Um, Previous work of ours has shown that champions of the cause, community leadership plays an incredibly important role. That when there is a local champion who's respected, who has strong social capital, is well connected across the sectors. And often these folks are also philanthropists locally, that they have magical powers to bring people to the table. And so you're right, Glenn, that some communities just simply don't have these folks, particularly rural areas where support systems are simply lacking. And so it's not that there isn't any community leadership, but the community leadership is stretched thin. And so that is a story that we hear time and time again, that local leadership matters. And often this is strongly connected to governance mechanisms and the role of local governments. In rural areas, they're stretched thin, there's little supports, little resources, so less likelihood of local governments playing a strong role. But in other sort of well-resourced, stronger communities where there's political leadership, where there's local philanthropy actively involved, local governments seem to be much more engaged in not just playing a partner role, but often also leading the charge. Some of our previous research shows that across the country, about half of them are led by nonprofits, the other half are led by government agencies. And I think that's a strong indication of the commitment to the work of these sort of local governments, and wanting to shape local policy, local strategies. And so in those cases, we see much more diversity of stakeholder engagement, including the medical sort of healthcare sectors. And so I certainly see, from our previous research and current work, that both of those things work, almost hand in hand, where there's local leadership, there's also local active, government engagement in this work. And so leading to more diverse stakeholder engagement, and where both of those factors are absent, we see a lot less of diversity of stakeholder engagement, as well as particularly engagement of the medical sector in the community's work. So both of those factors are incredibly important and vary from community to community.
Fantastic. Thank you so much, Dr. Valero. So we are getting to the end of our hour. I want to again thank this collaborative research team for sharing with us your work. Remind everybody this work is still underway, so welcome you to keep tabs with the progress and the ultimately the final findings from this study that will be forthcoming in future months. Stay tuned to the website for more work from this great research team. Thank you again to Dr. Chang, Dr. Valero, and their partner Mike Nichols in Houston that we heard from today. Reminder, if you want a certificate of completion for this webinar, please complete the survey that you'll see at the end of the session that'll pop up here in just a minute. If you want to get a recording of this website, of this session today, that will be posted on the Systems for Action website very shortly. So if you've got colleagues who missed this, you can view it online. You'll see a schedule of our upcoming webinars listed on this slide. So please feel free to join us. We do these regularly. Please make sure to join us. And also a reminder, we do have a current call for proposals for new research studies out on the street right now. Deadline is October 5th. We'll be hosting some virtual office hours for those of you who may be considering applying for funding to do your own study to test a novel system alignment approach. So feel free to drop in on one of these office hours weekly if you want to bounce your idea off of us and get feedback about submitting a research proposal through the Systems for Action 2022 call for proposals process. Thanks, everybody. Thanks for joining us. Hope to see you again soon. Enjoy the rest of your day. So long, everybody.